Most honorable and distinguished faculty of today's Bounce Back session, led by Dr. Ram Chadda, Dr. Samir, Dr. Shreel, Dr. Omkar, Dr. Avyay, and all our distinguished delegates across the country who have gathered here to view the next installment of the series of Bounce Back. Welcome back to Bounce Back. We started this a fortnight ago, and the very first installment focused more on the conservative aspects of managing spinal disorders. And now we move on to the intrigues and the clinical challenges and dilemmas on the surgical side of the spectrum. And we have an academic feast in store with a galaxy of most eminent faculty to lead the discussions for today. A little bit about Integrace. As you know, we are one of the youngest entrants today in the pharma industry, having completed 2.5 years of our journey. And in these 2.5 years, we have acquired the proud repute of being recognized in the top 100 in the pharma. And we are the youngest in the top 100. So we have leadership positions in the area of cilostazol and fixed dose combinations of pregabalin with nortriptyline and mecobalamin. And this would not have been possible without the confidence of over 30,000 doctors who placed their trust and confidence in the quality medicines of Integrace for benefit of their patients. And we operate throughout the country. So Integrace has created numerous scientific platforms, and that's what we are committed. We endeavor to create all these platforms of excellence to upgrade knowledge and skills. And one of the biggest programs that we have done, where we've got more than 3,000, 4,000 doctors participating, is the International Best of Orthopedic Techniques Live International Convention. And Professor Ram Chadda himself is one of the most distinguished program directors, and he's been associated with the Boot Live International right from its inception 3 years back. Apart from the Boot Live, we have also done the National Web Academies of Boot, Best of Orthopedic Techniques. And we have a scientific app called WeConnect Health, which is a repository for all the latest updates and scientific information in the field of orthopedics. We've been certified as a great place to work in recognition of our contribution to the medical fraternity and for the experience that we provide to our employees in our organization. This is something indeed very proud, and we owe it to all our valued customers who place their confidence in Integrace. We owe it to you. So to introduce the eminent faculty for today, I'm sure Professor Ram Chadda really needs no introduction. He stands as a colossus in the field of spinal surgery, one of the finest exponents, a great academician, a master teacher par excellence. So Professor Ram Chadda is consultant spine surgeon at Lilavati Jaslokan Global, ex-professor and head at the KJ Somaya Hospital in Mumbai, and ex-senior visiting consultant at Saifi, Wockhardt, Fortis, Guru Nanak, Raheja, and Apollo Hospitals at Mumbai. He's been the past president of Association of Spine Surgeons of India, Bombay Orthopedic Society, Bombay Spine Society, Chief National Delegate of Asia Pacific Spine Society, and council member of Asia Pacific Ortho Association. He has pioneered MICOS, minimally invasive cosmetic spine surgery, and he's also the pioneer of endoscopic spine surgery in India. He's won numerous awards to his credit: the J.B. Modi Gold Medal Neurotrauma, Spine Instrumentation Fellowship, Münster, Neustadt, Germany, Barrows Neurological Institute Fellowship, Phoenix, Arizona, USA, Nucleoplasty Freiburg, Germany, Scoliosis, St. Louis, USA, Minimally Invasive Spine Surgery, Seoul, Korea. So delegates, that's Professor Ram Chadda for you, and it's a great honor for me to pass on the baton to him to take us through the rest of the proceedings. Good evening, sir, and it's over to you now. Thank you.
Thank you very much, Mr. Anil Fernandez. We are indeed most obliged and touched by these kind words. I have with me a galaxy of young Turks, people who have been associated with spine surgery and are now the go-to people as far as aggressive decision making and proper implementation is concerned. We had the first program on non-invasive care. Today we move into surgical decision making, the why, how and what of surgery. And for that, I have my dear colleague, Dr. Sameer Ruparel. Dr. Ruparel is a consultant spine surgeon at the Jaslok Hospital and Global Hospital, and has been trained at various places all over the country and overseas, and is a proponent of minimally invasive spine surgery. We also have a young man from Indore who's a consultant spine surgeon in Indore, Dr. Avyay Rege. He has also been trained with various fellowships and is now embarking on a journey to practice spine surgery in the lovely city of Indore. We have two young men who are very well trained but are honing their skills further. Dr. Shreel Koirala, who's presently working at the Lilavati, Jaslok and Global Hospitals as a senior spine fellow. He hails from Nepal, has trained all over our country, and has made presentations both nationally and internationally. Dr. Omkar Shinde, the man from our very own state, Maharashtra, from Sangli, a very well trained young man who trained at the JJ Hospital and is right now at that stage where all that he has learned is being processed through working at the Lilavati, Jaslok and Global Hospitals. I welcome these young men who are a part of our team today, and I would call upon Dr. Sameer Ruparel to make his first presentation and take the proceedings further. Sameer, all yours.
Thank you, sir. I would want to formally introduce once again Dr. Sameer Ruparel on behalf of Science Integra and Integrace Orthopedics. I welcome all faculty, the eminent faculty and all the doctors for this Bounce Back Series 2. We have Dr. Sameer Ruparel, who's a consultant spine surgeon, Jaslok Hospital and Gleneagles Global Hospital. He has done fellowship of Association of Spine Surgeon of India, fellowship of Australian Institute of Musculoskeletal Research, Australia, and fellowship in minimally invasive spine surgery. We have Dr. Shreel Koirala, who has been the fellow spine surgeon Lilavati Jaslok Hospitals, Mumbai. He's the ex-senior resident Department of Orthopedics in Delhi. Post-graduation from MS Orthopedics at Ramaiah Medical College, Bangalore. Special interest in deformity correction, revision spine surgery, minimally invasive spine surgery, and has been the member of ASSI and SICOT. We have Dr. Omkar Shinde, as very well introduced by Dr. Ram Chadda. He is a fellow spine surgeon at Lilavati Jaslok, Mumbai, ex-fellow spine surgeon, Department of Orthopedics at GMC, Mumbai. Special interest in deformity correction, revision spine surgery, actively involved in various research work in the field of orthopedics and spine surgery, and a member of ASSI, SICOT, BOS, BSS, IOA, and MOA. And last but not the least, we have Dr. Avyay Rege, consultant spine surgeon, Indore. He has done his fellowship in spine surgery from Lilavati Jaslok Global, Mumbai, and ATLS Gold Medal Oral Paper Presentation at IMACON 2017, and has a special interest in deformity correction, revision spine surgery, and minimally invasive spine surgery. Thank you so much all the faculty members for your presence, and I request Dr. Sameer Ruparel to please start the proceedings of the webinar.
Sameer, please unmute yourself.
Yes, sir. So is my screen visible now?
Yes. Full screen kar lo. Thank you.
Yes, sir. A very good evening to everyone. I would like to thank Integrace Orthopedics and obviously Dr. Ram Chadda sir for giving us the opportunity to discuss about lumbar spine surgery. And I'm going to talk about the basics of lumbar spine surgery. In the previous session, we discussed about the conservative management of various pathologies affecting the lumbar spine. Today, we are moving a one step ahead, which is a difficult one. And I'm going to talk about everything about the basics. So whenever a spine surgeon contemplates a spine surgery, there are numerous questions that come to his mind, like who, what, when, how, why, and where. And it is very much necessary to have very specific answers about these questions before offering a spine surgery to the patient to get the expected results. We have covered the indications of spine surgery partly in the previous session, and I would just go through them. The absolute indications being very few, that is a patient with progressive neurological deficit or a cauda equina syndrome, a patient with myelopathy, or those having pathological instability due to fractures, tumors, or infections. Now, the major bulk or the major workhorse of the spine surgery is a relative indication in which the patient has unrelenting pain despite conservative trial and where the patient opts for surgery. And it includes most of the degenerative conditions of the lumbar spine that we see in our daily practice. Now, let's start with the case example. This is a 28-year-old gentleman who complains of low back pain since 6 months. And he has been having radiating pain to the left buttock and posterior thigh. Neurologically, he is normal. And he is not at all getting better with conservative treatment and affecting his activities of daily living. And now he is saying, doctor, please get me rid of this. I want to get rid of this pain and I'm willing to undergo the surgery for the same. So this patient was operated. Surgery was done. As you can see, there's a very good clinico-radiological correlation. The patient has left leg pain, buttock and thigh pain. The disc is also on the left side, and there's no instability as such. And the surgery was done, but the patient is back to square one. There's no relief at all. So what went wrong? So it is very much necessary to know when not to operate. And a clinico-radiological correlation is a must, and it's also necessary to look for spine masqueraders. When this patient was evaluated in much detail, it was found that he was actually having involvement of the sacroiliac joint and had an HLA-B27 which was positive. So coming back to the same case example, suppose this patient did not have SI joint involvement. So what was the kind of surgery that we would be thinking of? It would only be a discectomy, or it would be just a decompression, a fusion, in which there are various types of fusion that can be done, a posterolateral fusion, interbody fusion, and also is this patient amenable to a minimally invasive spine surgery? So let us look at one by one at the most commonly performed spine surgeries in the presentation ahead. The most common pathologies affecting the lumbar spine are the disc herniation, as you can see on the left, the lumbar canal stenosis, and the instability due to numerous causes affecting it. And it is very simple. So a patient is having a disc herniation. He is usually treated with a microdiscectomy. The disc, which is the offending agent, is removed and the nerve is seen free and the patient gets better. Similarly, if the pathology is a lumbar canal stenosis, then we do a lumbar laminectomy and we decompress the spinal canal. Similarly, if the patient has instability in addition to this, for example, if the patient has degenerative or a lytic spondylolisthesis, then a fusion is indicated in this patient. But is it really so simple? It is actually not. So we actually look at variables which are patient dependent, surgeon dependent, as well as radiograph dependent. For example, a patient dependent being the patient's build, height, profession, whether the patient has a mechanical low back pain or a discogenic back pain, his age, what is his physical demands. Similarly, surgeon dependent, that is a technique that he is most comfortable using, as well as the feasibility of using MIS and having the proper setup for using MIS. Similarly, this was a recent paper which was published in which a scoring system was developed whether to fuse or not to fuse the patients in low-grade degenerative spondylolisthesis. And you can see there are so many numerous variables that have been stressed upon and have been given values. For example, if you just see the radiological factors, there is segmental kyphosis, there is dynamic spondylolisthesis, the disc height, the facet diffusion, the orientation of the facet joints, the demands of the patient, the age. So all in all, spine surgery, though we know that the most common pathologies affecting the spine being the disc, the canal stenosis or instability, to provide a particular what surgery needs to be done and what treatment options need to be given to the patient depends on a huge number of variables which varies from person to person. So for example, I'll just go through the common surgeries that have been performed, that is the discectomy, the laminectomy and fusion, just in short, and give gross indications and the surgical technique of the same. For example, for discectomy, when to do? A patient having progressive worsening of symptoms not relieved by conservative management, a dermatomal pattern of symptoms, the structural cause being identified, and an extraspinal cause which is being ruled out. After adequate counseling, the patient is advised to discectomy. And what are the principles of doing a discectomy? The main principle is to free the neural tissue. That is done after subperiosteal exposure. The bone is removed with a laminectomy or a laminotomy. Phlebectomy is done and the lateral recess is decompressed. And finally, the disc is removed and the nerve is set free. However, there are numerous ways even in which a discectomy can be done. The conventional discectomy involved a laminectomy, removing the whole part of the lamina, which involved long incisions, lot of muscle retraction. But now we do use minimal access surgeries in which there is posterior muscle sparing and microscopic lumbar decompression or MLD using a McCullough's retractor or tubular endoscopes are being used these days commonly. So microdiscectomy is basically a gold standard. It usually involves a small incision these days and uses an operating microscope or a surgical loops. Now coming to decompression, that is laminectomy. This is almost similar to a discectomy except that the patient usually comes with a claudication pattern of symptoms. And the counseling, the conservative management and clinico-radiological correlation is a must. Laminectomy, again, the basic principle is to free the neural tissue and the basic steps are the same. Now coming to spinal fusion, there are various types of spinal fusion. One is the onlay, that is a posterolateral fusion, and there's an interbody fusion in which numerous techniques of approach have been described in the literature. Now lumbar fusion is effective treatment option to stabilize a painful motion segment, and they are of two types broadly, that is a posterolateral fusion and an interbody fusion. The posterolateral fusion is a technique that involves laying bone graft in the posterior spinal bed to form a bony ridge, which is a traditional and the conventional method of fusion. Similarly, interbody fusion involves laying the bone graft between the two vertebral bodies after removal of the disc and the end plate preparation. It involves a large surface area for fusion in which compressive forces of the body weight act upon it and thus giving rise to better restoration of lordosis and fusion rates. Now, in the literature, supports interbody fusion or posterolateral fusion with better clinical outcomes. Now, what is PILIF? PILIF is basically a posterior lumbar interbody fusion which was devised by Cloward in 1963. The fusion surface is prepared, that is the end plates after the discectomy, as well as intertransverse and the facet joints may also be utilized in this technique. What are the steps? We expose after a subperiosteal exposure, we decompress and discectomy is done. And these are the additional steps. That is the end plate is prepared, a cage or an autograft strut is inserted, and a graft interbody or an intertransverse as well as facet fusion is done. This is an example of a mobile lytic in a young patient which was operated by PILIF. But there are some limitations because of which there is TILIF, there is XLIF and OLIF which has been now into vogue. That is, PILIF involves a lot of root retraction and which may give rise to post-operative leg pain or paresthesias. In revision spine surgery, there may be it may cause battered root syndrome or epidural fibrosis, as well as it is difficult to approach a far lateral disc using this exposure. For example, if a patient has a high lumbar disc where we cannot retract the spinal cord, it is very difficult to approach the disc or cause fusion with the help of a PILIF exposure. This led to the inception of TILIF. Now, the basic difference between PILIF and TILIF is that the TILIF involves removal of the resection of the facet joint without much retraction of the nerve roots or the cauda, and the disc space is accessed. So the indications are much broader. You can use it. You can access the facet joint, which is a virgin area in the revision spine, far lateral disc, high lumbar disc, and it is an extracanal technique which does not give rise to epidural fibrosis or arachnoiditis. The fusion rates, if not similar, they are better, and there is no root battering in TILIF as compared to PILIF. For example, this is an ideal indication in which a TLIF is preferred over a PLIF. In lytic lifts, this is when there is foraminal or extraforaminal compression, in which removal of the facet joint frees the foraminal or the extraforaminal canal, in which TLIF is much more better than a PLIF exposure. Lateral disc, as you can see over here, removal of this facet joint, accessing the disc and removal of the disc space and preparation of the bone graft for interbody fusion is very much ideal with TLIF in this case. Similarly, a failed spine surgery, as I described before. So fusion rates have been very good, almost in the range of 97%, and excellent 5-year follow-up results have been available for TLIF now. And I have already enlisted the advantages of TLIF. In short, it is the gold standard for interbody fusion these days. Now coming to MIS surgery. MIS has numerous advantages like less postoperative pain, there are smaller incisions with faster recovery and blood loss. And all the described techniques are now feasible or amenable with MIS techniques as well. So this is a microscopic assisted tubular endoscopic decompression. Similarly, percutaneous screws can also be put with the help of MIS TLIF. Not forgetting the safety of the modern OT setup, which is also required, along with imaging and neuromonitoring, which increases the safety of spine surgery to very high levels these days. Thus, coming back to the previous slide, spine surgery is ever evolving, and it is very necessary to know the answers of all these specific questions before embarking on an open or an MIS TLIF, so that the best results can be delivered to the patient. Thank you.
Thank you very much, Samir. That was an excellent presentation. And now we would walk through our journey today with a couple of case presentations. The cases will be presented by Dr. Shreel and Dr. Omkar and will be moderated by Dr. Samir and Dr. Abhyay. Over to you guys.
Thank you so much, sir. Good afternoon, everyone. Welcome back to the Bounce Back webinar series. Today we are discussing about case scenario on options versus choices, low back surgery, what, how, and why. Coming to the first scenario, here we have a 38-year-old male who is an entrepreneur, complains of both lower limb weakness since 15 days. Initially, the lower limb pain was associated with low back pain, which gradually decreased over 2 to 3 days' time. He also has difficulty in walking. He is not able to walk. On examination, we found that in both the lower limbs, below the knee, the power of both the lower limbs was absolutely zero, whereas the power of both the lower limbs above the knee was grade 2 to 3. He also had S1 hypostasia 40% than in the upper limbs, and his bowel and bladder were incontinent. These are the clinical videos. We can easily see here that he has a bilateral foot drop. Let me go a little bit forward. And yes, here you can see that when he is able to flex his hip, the hip goes into a little bit of rotation, then he is able to flex his hip. Also, we can see that he is not able to sustain an active SLR completely. This is the amount of active SLR that he does in both the lower limbs.
So, Dr. Shreel, if I could interrupt you for a moment,
Yes.
When you see this video, when you examine this patient, what comes to your mind? What can you make a differential diagnosis? Can you figure out what could be wrong with this patient?
Yes, absolutely, sir. So coming to his clinical picture and scenario, he is a relatively young male who does not give any history of comorbidities. He gives acute history of low back pain, inability to walk or move around since 15 days, and with a incontinent bladder and bowel. On examination, what he had is lower limb weakness. So these are decreased or absent plantar ankle and knee reflex. So these all pointers are towards a lower motor neuron disease, most probably at the level of upper lumbar spine.
Correct. So how did you go ahead with this then?
Yes, exactly, sir. So I would also want to emphasize here that he had a pressure ulcer or a pressure sores on the lateral malleus of both his foot, which also denotes that he is immobile for a longer period of time. So what next? How do we investigate him further? Do we do blood investigations, X-rays, MRIs? What next? What all can be done? Coming to X-rays as option one, as we discussed in our previous webinar, we got an X-ray LS spine AP lateral inflection and extension, and here we could see that his spine was fairly normal except for a lytic lesion at L5.
Okay, so when you look at this X-ray and you clinically think that it is something to do with the higher lumbar spine, how do you figure out whether it is because of a higher lumbar issue or is it because of this lysis?
So the patient complained of less back pain and more of bilateral lower limb weakness, number one, and number two, we cannot see any instability in the lytic lesion what we have over here. So the weakness because of this L5 lysis is highly unlikely according to me, sir.
Okay. So then what next did you do?
Yes, we went ahead with the MRI. In MRI, we screened the whole spine, and while screening of the whole spine, we could see that there was a space occupying lesion behind the body of L3, and there was a degenerative disc at L5S1. Coming to the sagittal view, here we can clearly appreciate a big space occupying lesion, most probably an intervertebral disc, behind the body of L3 vertebra in the sagittal cuts, T2 weighted, and in the T2 weighted axial image, here we can see that this is L1, L2 disc space, this is L2 vertebral body, and as we look down from the L2 vertebral body till L3, L4 disc space, we can find that these are space occupying lesion extradural, which is compressing the theca.
So there is also involvement of an L4-5 disc over here. So this patient probably has multi-level pathologies. So as you rightly mentioned that there is a disc which has come out, and it is probably a disc which has come out and involving and it has probably superiorly migrated, but there's also involvement of L4-5 disc, and as well as the patient has lysis.
Yes, sir.
So out of these multiple pathologies, which probably is the cause of the symptom in this patient?
So the most probable cause of this symptom is the disc, which is L3, L4 disc, which has superiorly migrated, sir.
And why not the L4-5 disc?
The L4, L5 disc is also the L4, L5 disc is causing thecal compression over here, but the most important compression what we see in the sagittal view right now is the L3, L4 disc, which is prolapsed, and because of his neurology, sir, he does not have any L4, L5 neurological symptoms which he is complaining of.
So, but he does have ankle and toe weakness, but I think the main thing is that he also has a subtle weakness in his, so grade 2, grade 3 power involving his hips as well as the knees.
Yes.
That probably points out that the lesion might not only be L4-5 or the lysis, and it may be a little higher as well.
Yes,
So how fast did you go ahead with getting the MRI and the X-ray done in this patient?
sir,
And would you usually do the same in all the patients?
no, sir. These kind of patients, a little bit of quick action is very much required in these kind of patients. We did not wait for our blood investigations. We did not wait for any other investigations. We straight away got an X-ray and an MRI done immediately after the clinical examination of the patient.
So this is kind of a, if I may mention that this is a cauda equina syndrome.
Yes, we can call it a cauda equina syndrome, who presented it to us after 14 days of the initiation of syndrome.
So Dr. Abhay, you have done quite a lot of review of literature about cauda equina syndromes. So what has been documented in the literature with regards to the timing, with regards to the bladder retention or bowel retention, and the quickness of this and the results which we get after doing a quick surgery in these patients, an early surgery in these patients?
So based on recent literature, what it says is that if you have diagnosed a patient who is in cauda equina syndrome, you have to first look at that is an absolute emergency, that is a given. However, if the patient is in urinary or bowel or bladder retention or incontinence, then it becomes a further emergency. In case of incontinence, a 48-hour window will give us a good result in terms of neurological recovery. The chances are higher, but retention does not show as good results. However, it also says that within 48 hours, the surgery gives the patient the best chance of neurological recovery.
Okay, so within 2 days, if the patient is operated, there are good chances of neurological recovery. Unfortunately, in this patient, the patient has been in the syndrome since almost 14 days now.
Yes.
So it is very much necessary that we explain poor prognosis of neurological recovery in these patients. So Dr. Sheel, any MRI pointers to know whether the bowel or the bladder is involved?
Yes, exactly, sir. Coming to the same thing, it is very essential to sort of interpret and observe the MRI. Here we can see that in the sagittal view, T2-weighted sagittal view, we can see a big distended bladder, which is almost reaching up to the L4 vertebral level. So this is a telltale sign which shows that his bladder is full, and most probably there is an incontinence in the bladder, sir. There is a neurologic bladder.
So any other investigation that you would like to do in these kind of patients, as mentioned by Dr. Abhay, to know the prognosis as well?
Yes. So what we can do is, if we can also get a USG KUB pre-void and post-void for getting to know how the bladder is functioning. If the post-void residual urine is less and the patient is able to void independently in the control, then yes, his bladder is preserved. But if there is no difference, or there is not much difference between the post-void and pre-void, as in our case right now here, the pre-void was 820 ml, whereas the post-void residue was 700 ml, which shows there is a neurologic involvement of the bladder.
Right. So let us ask Ram sir about his principles of managing a cauda equina syndrome, a patient in general.
And as far as I am concerned, very few patients come with full-blown cauda equina within the first 48 hours. So you have to counsel them for a very, very guarded and poor prognosis. I always believe in involving my urologist from day one. I also involve my neurophysician from day one. Why do I do that? A lot of cauda equina may mimic something like a Landry-Guillain-Barré syndrome, or something which is called acute inflammatory demyelinating polyneuropathy. Now, these are ailments which we don't know much about, but can at times present to us like cauda equina and are ascending in nature. We have to be extremely careful with our cauda equinas that we don't miss this. The other thing which is very, very important is to palpate the pulsations. Please remember that there is an entity called Leriche syndrome, where you may see a patient who looks like a cauda equina but is actually a vascular insult, and that's an even greater emergency, and we have to have the vascular guys in. So these are few points or pointers that I may like to share in cauda equina. Palpate the pulsations. If there's absent dorsalis pedis or posterior tibial, go up, palpate the popliteal, go up, palpate the femoral. If all are absent and the limbs are getting cooler, it may be actually a acute Leriche and not necessarily a cauda equina. So keep these at the back of your mind. But if it's vascular intact, but it is giving an ascending history, then get your neurophysician in to rule out a Guillain-Barré, or what they call now acute inflammatory demyelinating polyneuropathy.
Right.
So we have to keep that at the back of our mind. Plus, as I said, we are seeing a lot of very odd presentations which are viral in nature in the COVID phase right now, and a lot of them remain unexplained. So painless neurologies are coming, so be aware of that.
Right, sir. Sir, and any role of steroids? Do you usually prefer to give steroids in these kind of scenarios? And
Well,
if
I'll
so,
be very, very frank. We have our neurophysicians who actually use aggressive methylprednisolone sodium succinate, which is in a dose of at least 1 gram a day for about 4 to 5 days. But truthfully, I'm not too sure. In this young man, yes, we could because he's otherwise stable. But if I had a patient who was 70, 75 and who had other comorbidities, I would be a little bit skeptical with the use of methylprednisolone sodium succinate, more from the side effects and with less evidence as far as the efficacy is concerned. But a lot of our neurophysicians are happy giving that bolus of steroid and actually continuing with it. Truthfully, unexplained pathologies where you're not too sure, it's good to go with the neurologist first by the time that you get your diagnosis in place. And maybe in a few of them, steroids may work. Maybe a lymphoma, steroid may work. Maybe some non-infective early myelopathy, the steroid may work. So these are situations where you go with the neurophysician in an institution, you could probably use it, but knowing very well that it's only a temporary stopgap and may or may not work, there is no real evidence to support it.
right, sir. Sir, in your experience with regards to the timing of the surgery, if we are, as mentioned by Dr. Abhay, and he has reviewed the literature. So what is your experience if such a patient comes to us and we operate him within 2 days of development of symptoms and the neurological recovery that you have seen in your experience?
Okay. If my patient has come within the first 48 hours, I want to do the surgery ASAP. That means I want to do it within 8 to 10 hours of his coming to me. Ideally, with everything worked around, even if it's in the middle of the night. However, in this particular patient who's come to us at 14 days, I would probably do it the next day, first case in the OR, if possible. So that's the difference between a 14-day presentation and a 48-hour presentation. In the first 48 hours, I would rush in. Same man, 38-year-old, I would not wait had he come in the first day or two. Absolutely not. This man, we did wait and do it the next day. That's how it is.
Right, sir. So, Dr. Shreel, over to you.
Yes, sir. So getting the USG, KUB and pre-void, post-void done, we clearly knew that he had a neurologic involvement of the bladder. Now the question is, what do we do? Do we do a conservative treatment, which most of us now know that it is not an option? Do we do a selective nerve root block, or do we go for a surgery?
We'll definitely go for a surgery in this.
So we went ahead and we did a wide laminectomy done. We decompressed all the nerve roots, and we found a big 5 centimeter, about a 5 centimeter disc, which was lying behind the body of L3 vertebra.
Okay. And how about L4-5 disc and L5 lysis?
So L5 lysis was not touched. L4, L5, we did a decompression and foraminotomy.
Okay. And did you do anything with the disc?
Yes, definitely. These kind of things we generally send it for histopathology examination, sir. This is a recently operated case, and his histopathology examination is still awaiting.
Okay. So, so Ram sir, we would like to discuss regarding the planning of this patient as well as the counseling that we need to do with this patient before embarking on the surgery. Since he already has a lysis at L5, we don't know whether that has been an ongoing cause of his back pain and whether we should tackle it in one go. Similarly, there's a small disc at L4-5 and a huge disc which has come out from L3.
Well, I counsel this patient telling them that the space occupying lesion behind the body of L3, extending from the L2-3 disc up to the L3-4 disc below, on the MRI showing to be approximately 4.8 centimeters, needs to be removed. And everything else is secondary. We also said that since we are doing that and L4-5 is in contiguity and in the same surgical incision, we shall have a look at both the roots of the L5 on either side as far as the L4-5 disc level is concerned. And if there is a fragment, we shall pick it up.
Right.
If you notice, the top marker shows the top of the surgical decompression, which is at the L2-3 level. And the lower marker is showing the foramen of L4-5 on the L5 nerve root. So we went and did a bilateral foraminotomy, looked for any loose fragments, if any. In such a patient, if there is a small loose fragment, we would pick it up, but we would not necessarily go in and do a formal discectomy at L4-5 because the aim is just to do a foraminotomy over and above a good decompression at L3-4, which has gone up. So that whole area was completely decompressed from 2-3 to 3-4 disc spaces. Did a foraminotomy bilaterally at 4-5. Did not venture into the lysis to destabilize it. Had counseled the patient earlier that if need be at a later date when things are fine, if he ever needs surgery for fusion, we would look at it. Today, I didn't see anything. The 5S1 disc to me was comparatively pristine. I didn't want to play around with it, and nor did I want to destabilize him further with an L5 lysis becoming a listhesis.
Right.
So I did a soft tissue surgery here.
Right, sir. So it is very much necessary that the L5 lysis, though it is present, we did not touch the L5 lysis since it was probably not the cause of his present symptoms, though adequate counseling is very much necessary. So, Dr. Shreel, can you go to the pre-op MRI as well as the X-rays, and we can ask Ram sir about the need for fixation, if so, in this patient or not? Whether should we keep implants as a backup in this patient, or we should go with the fixation also in mind, and if so, when should we fix?
Well, I'll be very frank. In this particular patient, my gut feeling was that I wanted to get out without a fixation because my compression was very far from the instability. The instability was 5S1, my compression was behind L3 vertebra. But yes, if I had to do too wide a decompression, if for any reason I had destabilized the lysis, in that case, I would probably have to consider a fixation, and I would try to be as limited as possible. So
Right.
in this young man, I'll be very frank, I would not like to do the whole hog of L3, L4, L5, S1. No, I would not do that ever. Even now, if later in life I have to do a surgery on this man and he starts walking and he recovers neurologically, I'll probably restrict myself to 5S1 for the instability at that stage. But I would not here consider 3, 4, 5S1. No, it's overkill as far as I'm concerned.
Right, sir. So it is very much necessary that we know what levels that we need to operate, what is the exact pathology that we need to target intraoperatively, what goes into the counseling of the patient with regards to the pathology and the symptoms that he is having, as well as the prognosis. So there are numerous things that we learned in this case, and now we will go on to the next case, as well as a few learning points from Dr. Shreel before we go on to the next case.
So the learning points here in this case is a good clinical evaluation of a patient will lead to a good surgical outcome, and the history, his or her story, is very much valuable, and we should try to get important points out of history.
Right. Thank you so much, Dr. Shreel. So can we have Dr. Omkar?
Should I share it, sir?
Please go ahead.
Am I visible, sir?
Yes, visible as well as audible.
Good afternoon, everybody. I welcome you all to this Bounce Back webinar series, episode 2. This is the second case we are presenting. A 70-year-old female homemaker. She came to us with a low back pain with radiation to left lower limb since last 6 months. She was able to walk only few steps, that too with walker support. There was no any bowel or bladder symptoms. She also had a history of selective nerve root block taken for his lower limb pain 2 months back elsewhere, and she got temporary partial relief of the pain. On examination, the left SLR was positive. On neurological assessment, we found a 20% hypoesthesia at left alpha and S1 dermatome as compared to the right side, and left EHL was weaker as compared to the right, which was 4/5 power.
So, Dr. Shreel, based on the history and examination, what do you think is the level of pathology and what would be the pathology in this patient?
So the level of pathology in this patient would be a lower lumbar region, sir, because she has a EHL which is weak, and her L5 and S1 is has 20% hypoesthesia than on right. So it should be a lower lumbar pathology, sir.
Most probably involving L4-5 or L5-S1.
Yes, sir.
Right. So can you enumerate what are the dermatomes or what is the power that you see if the patient has an L4? So most commonly we see L4-5 and L5 weakness or some pathology in those levels. So what corresponds to the loss of power at L4, L5 and S1 nerve roots?
Yes, definitely, sir. So if there is a coming to S1 first, if there is a S1 nerve root involvement, there would be a hypoesthesia on the outer aspect of the foot, the sole, and the lateral aspect of the calf. The patient would also have a weakness of FHL, FDL also. If there is a L5 root lesion, then there would be a hypoesthesia on the medial aspect of the foot between the between the great toe and the second toe. That is where we would look for the hypoesthesia and a EHL, EDL weakness, sir.
And L4?
L4 would give the L4 would give rise to a plantar and plantar dorsiflexion, everter weakness, along with sensory hypoesthesia on the anterolateral aspect of the leg, sir.
Right. So basically L4 affects the ankle dorsiflexion, L5 being the EHL, and S1 being the plantar flexion. Yes. And the autonomous areas being the medial malleolus, the first web space, and the lateral aspect of the foot for L4, L5, and S1. So this gives a general idea about what the level of the pathology would be. So Dr. Omkar, over to you.
Yes, sir.
Just for a moment, Sameer sir, what role do you think the selective nerve root block that this patient had taken a few months back, what role do you think it plays in this patient's clinical picture?
So if the patient has taken a nerve root block, probably the results of the nerve root block, as we discussed in the previous section, is very variable. Without seeing obviously we need to see the X-rays and the MRI of this patient. But if she has got temporary relief, probably that we expect in a patient who has had a nerve root block. And she has had adequate conservative treatment for the same. And she has come back to us.
Right.
Yes, sir. Should I move ahead, sir?
Yes, please go ahead.
So upon evaluating the patient clinically, we went ahead with the basic thing, that is the plain radiography of lumbosacral spine with dynamic views. On dynamic views, we are able to see the certain radiolucency between the lower three lumbar segments, that is at L3, 4, 4, 5, and 5S1. Along with that, we see a listhesis, that is anterolisthesis of L4 or L5 and L5 or S1 with mild retrolisthesis of L3 or L4 also visible on dynamic views.
So Dr. Omkar, could you elaborate on the vacuum sign that you have mentioned here? Could you elaborate on its significance, please?
Yes, sir. So the radiolucency, which is actually very well seen here on the extension view of lumbosacral spine, it denotes there is intersegmental motion, that is there is a instability in between the segments, so they demand a more rigid thing like stabilization for their for the symptoms to improve.
So probably the patient might be having a mechanical low back pain component along with the radiating claudican pain that she is having. So can you, for the benefit of the delegates, can you point out the instability, the vacuum sign that is being seen on the flexion and the extension?
Yes, sir.
Sir? Yes. So it is not seen on the other side of the X-ray, right?
Right, sir. Right. It is
Right.
more seen on extension view only, sir.
Fine. And also you got the MRI done?
Right, sir. Next thing, we did a 3 Tesla MRI of the region. Here we can see sagittal titulated images, which are confirming the listhesis, which we have already seen on the X-rays. Also, we have got axial images at the affected levels, axial T2 images, which are in addition to the X-ray showing significant neurological compression, mostly at L4, L5 level. Then after that at L3-4 also, and bilateral foraminal stenosis at L5-S1 levels also. In addition to that, we are also able to see the fluid fill facets, which are seen very markedly at L4-5 levels and also at 5-S1 levels as well. At 3-4 levels, we are seeing a slightly different orientation of the facet, which are looking more vertical as compared to the horizontal orientation at the L4-5 and L5-S1 facets.
Right. So Dr. Avyay, do you think that the clinical symptoms and the radiology of the patient, do they correlate with each other?
So most certainly, I think that they do correlate because as Omkar said, she has an S1 hyposthesia, if I'm not wrong, and she also has pain radiating down to her left lower limb. If we look at the axial cuts of this MRI, she has severely stenotic canal at all 3 levels, most so at L4-5. So it kind of correlates to what the clinical history of the patient was.
Right. And just based on the radiography, if we just look at the X-rays and we just look at the MRIs, what probably would be, if you can enumerate for us right from the start what Dr. Omkar mentioned, the signs of instability or the causes of her mechanical back pain that we see on the radiographs. I mean, this patient has such a huge markers for all these symptoms that she is having.
Yeah, so basically she has mechanical back pain, which can be attributed to the instability at the 2 levels that she has, L4/5, L4/L5 and L5/S1 namely. And that also is causing the pain at her lower back, as well as the radiating pain to her lower limbs might be because of the pinching of the nerve roots, so as to speak, on either side. The left lower limb more so because there is a slightly higher stenosis on the left side.
Right. So there is listhesis, there's vacuum sign which is seen on the X-rays. On the axial cuts, we can see fluid fill facets as well as the sagittal facets on the MRI. So all these probably are the causes of her back pain, if we can say, but not necessarily. Fine. So Dr. Omkar, what did we do next?
Right, sir. So as per the theme of today's webinar, that is options versus choices, we actually had 3 choices in front of us after this scenario. But having tried conservative treatment for a longer time and having not improved with the selective nerve root block also, so we preferred to go ahead with the surgical management.
So basically you gave all the 3 options to the patient and let the patient choose whether the patient wants to go for a surgery or not. And if the patient denied a surgery at this moment and wanted to go ahead with the conservative line of management, you would do so, or would you not?
Sir, I would go ahead a bit aggressively in this scenario, sir, because the patient has been suffering since last 6 to 7 months. She already had a selective nerve root block, which after which she had a temporary partial relief of the pain. And presently she is able to move only a few steps, that too with support of walker due to her pain. So I think it is the right time to go ahead with the surgical management, sir.
Right. Okay. So can we ask Ram sir about the safety of spine surgery? As soon as the spine surgeon utters a word about the surgery, the first question that the patient says that I may land up into paralysis, or I don't want any implants. So how do you counsel this patient with regards to the prognosis and the outcomes of the spine surgery?
Well, I'm very clear. One, I never sell the surgery. I let the patient buy it. This is something I've stood by. Next, I also try and do less to get more, which you must have realized in the previous patient where I said that I wanted to do less invasive and not put in an implant as far as possible. However, in this particular lady, one, yes, I would counsel her family, try and elicit if there's some hidden bladder bowel dysfunction which is also creeping in, which comes in with a lot of ladies who don't share it because it's a stigma, and try and find out how really disabled she is. If after that she is still not willing for surgery, I would actually tell her that she's probably asking for things to worsen sooner or later, and she may need surgical intervention, and she should think about it earnestly. The only other thing which I would look for in this lady is the quality of bone. So I would also simultaneously want to treat her for a bone density issues, if any, and check it out and correct it. The reason being that if I am planning surgery in this lady, it's surgery for decompression and surgery for stabilization, which means I'll need a larger surgery than what we did in the previous gentleman where we did just the decom. So as I look at it, I walk my patients through it. I counsel them with an idea that there is an element of risk in surgery and there is an element of benefit in surgery. But I also tell them that there is a risk in waiting and there is very little benefit in waiting in a lot of situations. I also tell them that lumbar canal stenosis has an up and down curve, and there are only selected windows when the claudication cycle needs to be broken. And if we miss that window, if we don't make the right choice at the right time, we may miss the bus. So I slowly walk them into it. Yes, I don't force them, but I let them take a call, and almost 80 to 90% of them keep coming to you repeatedly, go back home and come back and do consent for an intervention sooner or later. But as I said, in the older people, responsibility is much larger on our side because there are medical comorbidities, there is poor bone density, and all these things. Possibility of going to intensive care for a day post-surgery, a prolonged recovery. So all that has to be kept in mind before offering them surgery. But yes, we need to counsel them. And we also need to tell them that in the best case scenario, 95% of them will do well with surgery, which is a fairly large number. And 4% may not do as well, but will still be able to continue with good quality life, though a little bit compromised. And there's just a 1% chance of things working against them. Having said that, and spoken to the entire family, a lot of them do consider intervention. That's how it is.
Right, sir. I think those are the pearls of wisdom coming from the master, because counseling, explaining the patient about the complications, the risks and the benefits are probably the most important aspect of spine surgery. So Dr. Omkar, did we get a DEXA scan done in this patient?
Right. Yes, sir. As Dr. Ram sir rightly said, the lady was postmenopausal since more than 20 years. And she has been on injection teriparatide since last 1.5 years for her pre-existing osteoporosis. So We continued that medication and we did a recent DEXA study which showed a good bone density with a positive T-score of 2.6 at the spine, at lumbar spine.
Just one question, Dr. Shreel. Do you always do only the DEXA of the spine or the other regions as well? And if so, why? Dr. Shreel?
Yes, sir.
So do you do the DEXA of what all regions of the body?
Yeah, so DEXA scan for bone density is usually done in the spine EP, one. Number two, bilateral neck of femur should be screened. And number three, the wrist joint, because these are the three places in the body which are more susceptible to osteoporosis. And these are the places where osteoporosis evolve and can be screened in a much sooner than wait for other parts of the body to get it screened.
Right. So Dr. Abhay, how about, I mean, you get a DEXA scan done for a patient. Have you seen in your practice patients getting a good DEXA score at the spine, but very poor scores in the hips as well as the forearms?
Yes, yes, it is quite common to have this thing. What happens is sometimes patients of this elderly age, they have things like osteophytes due to degeneration, because of which there may be a false positive DEXA score, T-score that they might get.
Right. So though we are spine surgeons, it may be a false positive, the DEXA score, which may be good. And it is very much necessary to look at the DEXA scores of the other parts of the body as well. This patient probably is on teriparatide and has shown a very good positive T-score of 2.6 at the spine.
Right. Yes, sir. And the lowest score was also minus 1.1, which was at forearm.
Right.
So she was out of, yes, sir.
Okay. So what do you, Dr. Omkar?
So after confirming her good bone density, we counseled the patient and went ahead to do L3 to S1 level decompression with stabilization.
Okay. So can we ask Ram sir about the decision making and planning about the levels of the surgery and whether to fuse or not to fuse in this patient?
Well, the only thing that you need to discuss here is whether I would put an interbody spacer or whether I would do posterolateral. Where I have the elderly, where I have settled discs, where I don't have gross instabilities, I prefer a posterolateral fusion rather than an interbody fusion, because at times interbody fusions may cause end plate injuries, may cause settling and sinkage within the end plates, and it may be a slightly more gruesome procedure for the elderly. Hence, if I look at multi-segmental complex lumbar canal stenosis in the elderly, which is where this lady comes in, I prefer doing good decompression. That means I've seen the central canal and I've seen all the 8 roots in this particular patient, and have a good construct restoring the lumbar lordosis. The aim is not necessarily to get a correction of all the listhesis. Mind you, a lot of them will correct, as in this lady, and you put in copious posterolateral bone graft. This is a reasonable option because most of these disc places are settling down. If you were to put in interbodies, one, you would jack them up. It's a better modality of fusion, but then unfortunately things like these at times work against you, because if you look at these disc spaces, a lot of these disc spaces after the correction are also about 5 to 6 millimeters. They are not the 8 to 10 millimeters, which is the minimum size of the interbody spacer that you would get in. So I am taking advantage of that I'm not really trying to jack up things, but maintaining anatomy as far as possible and putting a good decompression with a posterolateral fusion. So this is the way we would do the elderly. Plus with teriparatide there, already 18 months in, probably another 6 months to go, it would enhance the off-label use of the same, and we could look at a good outcome. And I hope that this lady in the long run does well.
Right, sir. So just last question before we close this case discussion. We have done a DEXA scan. It shows very good T-scores. But I mean, it is a part of the last bounce back series that we are going to do. What if this patient probably didn't have such good T-scores? So what would be the options of management in this patient?
Great. Now, if this lady had not been on teriparatide, if this lady had a low T-score, and if she was not neurologically disabled, I would first counsel her and put her on teriparatide. May I share with you that I have done a significantly large number of patients who have been initiated on minus 3.5 and below scores for teriparatide with an aim for surgery at a later date, operated them between 6 to 9 months of having given teriparatide. I also do it for patients who have Parkinsonism with osteoporosis who need a surgery. Parkinsonism is actually a big relative contraindication, but those who need surgery, I actually build up the bone quality to much better, and then use that 6 to 9 month window of good quality bone to go ahead and then do the surgery. But still, in all these patients, we've counseled them that we may at times also use cement augmented fenestrated screws, or we may at times not instrument them as the worst case scenario and do a purely uninstrumented fusion and go back to conventional times where we've done decompression, uninstrumented, copious posterolateral fusions with a corset, and then go slow in the rehab. So all these things are done, everything from full instrumented fusion with normal screws to dual core screws to fenestrated screws, cement augmented, to nothing at all, only posterolateral. So that's how the counseling goes.
Right, sir. So there are so many variables and options that are available for a successful outcome of the spine surgery. And now we have come to the end of our case discussions, and we are now going to the next phase that we have been waiting for, and that is the success mantra in lumbar spine surgery. None other than Dr. Ram Chadda sir himself giving a lecture and a talk on this.
Thank you very much. I think both Shreel and Omkar have done justice to the two cases which they have presented. We do have one more case. If time would permit us, we would probably present it. If not, we'll carry it forward for the next time, and we would do a review of literature after this. As we have bounced back again, I would share with you what I have practiced in the last 3 decades and share a success mantra in low back surgery. I have a disclaimer whenever I make this presentation that we as spine surgeons can make unhappy patients less unhappy. We cannot make them totally symptom free or very happy. If you want to do that, you have to either be a physician, or you have to do cataract surgery or knee replacement surgery. Cataract surgery and knee replacement surgery can change the patient's quality of life dramatically. Spine surgery is good, is very, very helpful, but we make unhappy people less unhappy. Yet, in our endeavor to change or fight the status quo, we have to stay hungry and stay foolish. We are a foolish breed. We attempt to tackle anterior lesions from behind as spine surgeons and vice versa. Significant disrespect to soft tissues and highest disregard for stabilizing structures of the spine, because for us decompression is more important. And at times we do more harm than good. As I've said always, we must plan for the outcome and not the income. We'll have 3 types of patients all our lives. The first is an acquisitive patient. Whatever you do for that patient, she or he is always unhappy. We have a contributive patient, a patient who is happy but still wants something more. And finally, we have the receptive patient, who's your name and fame propagator. Please remember, you should know preoperatively to choose the green name and fame propagator in the early part of your practice, rather than pick on a masquerader, a malingerer, a workman compensate patient who desires to hang a placard around his or her neck claiming that she or he have been very, very unhappy before and after the surgery. Please remember, you can treat a non-surgical patient who's unhappy for the rest of their lives and still have a peaceful night's sleep. But if you have an unhappy patient post-surgery, you lose your sleep and your happiness, and there is complete displeasure in anything that you do. To try and find out when to unlock my cutting devices, I have made a checklist. I'm making an attempt to bring some sanity to the foolishness and hunger of spine surgeons. I have a checklist which works on the why, which is the purpose, the how, which is the planning, the what, which is the process, and finally the execution, the artistry of precision, which is what differentiates a good spine surgeon from the rest. What's the purpose? Listen to your patient with curiosity, speak with honesty, and act with integrity. Is surgery the only option for this patient? Can I make him less unhappy? Is the risk-benefit ratio favorable? Does this particular patient need decompression, fusion, deformity correction, or a replacement? Finally, is this patient an outlier? Is he actually not a candidate for surgery, and is in that red box who's going to be always unhappy? The decision of a surgery and the rationale behind it is to be taken on counseling, and counseling. You need to spend 3 hours with the patient before surgery to do that 1 hour microlumbar decompression. Do that, it's an investment. If not, you'll be spending 3 months post-operatively trying to answer all the questions you could have in those 3 hours before the surgery. Please remember, the happiest patient is the one who buys the surgery and not the one to whom you've sold it. Coming to the planning, always rule out the hidden vitamin D3, B12 deficiency, the seronegative spondyloarthropathy, HLA-B27 positive, anti-CCP positive, RA positive, rule them all out. Osteoporosis with a T-score less than -2.5, pick them up, look for them. It's not just ladies, a few men over 60, 65 also have it. Diabetics have a higher incidence. Parkinsonism has a higher incidence. People on thyroid medication, higher incidence. People who are taking medication for seizures, higher incidence. Rule out gout. Rule out all forms of malingerers, including diabetes and other such patients who are unhappy for whatever reasons. Please remember, all patients have some medical comorbidities. A few of them, for reasons which are personal or related to insurance, may not share it. Pick on it, look for it, rectify it. Read the fine print. Always do a dedicated history and clinical evaluation. It will help you differentiate a non-spinal from a spinal pathology. We saw how the patient had sacroiliitis in one of the patients shown by Dr. Samir, where the surgery was done at the L5S1 disc on the left side. It also will help you differentiate a non-orthopedic from an orthopedic pathology. Finally, before lighting the lamp and initiating the process, take an informed consent. The consent should be taken and discussed in your clinic, not just an hour before surgery. Take an opinion of your entire team. Together, everyone achieves more. Check the readiness of your operating room. Is your imaging, implants, and instrumentation in place? If you need neuromonitoring, is it there? navigation, robot, if it's there, if you need it. Post-op, is the ICU bed there? Is your brace in place? Has your physiotherapist seen the patient? What are the dietary requirements and rehabilitations which need to be planned after the surgery? Lifestyle modifications. Have you discussed it with the patient? Have changes been made at the home? Have changes been made on the toilet seat? Have changes been made in his professional work as to how he's going to sit after the surgery? Finally, you have to decipher the Da Vinci Code of radiology. Please remember, radiologists report things as lumbarization, sacralization, transition vertebra. Please be very, very careful. Match the MRI with an X-ray. Insist on a pre-operative recent X-ray and match it with the MRI. During the surgery, you only have an intraoperative C-arm or image which matches the X-ray, not the MRI. So you have to know which mobile segment you are going to from below. Is it the last or the second last? And does it match what you see on the MRI, on the X-ray, and on the C-arm? They should be at the same level. Finally, as I've always said, spine surgery is a team effort. It's like playing cricket. The non-striker should have an opposing personality. Please remember, he should be one who is with you at your level and has the guts to stop you if you're going wrong. He should have a low power distance index with you. You can't be a 75-year-old operating with a 25-year-old who's scared to even breathe in front of you. Please have somebody in whom you have faith and who is going to openly stop you before you make the mistake. That stopping the other person is called having a low power distance index. It works in aircrafts between a pilot and a co-pilot and should work in the operating room between the spine surgeon and the co-surgeon. He should interactively indulge with you rather than reactively restrain from saying something on table. Create that in your team. Finally, go ahead with the precision. You must reset, refocus as many times as you need. Check the positioning, preparation of the skin, level marking, C-arm dreaming and positioning. Check your headlight, your loop, your operating microscope, your drill. Minimum instruments on the tray so that you have no fiddle factor. The nurse should know what you need. Keep your favorite instruments in place. You may just need 4 to 6 of them. Avoid the fiddle factor. And finally, always be prepared for the worst. Hope for the best, but be prepared for the worst. Have your tissue sealant, your Dura patch, your flow seal, everything on table. Bleeding, dural events, everything should be covered. Finally, I am foolish and I am obsessive with my pre-surgical checklist. And I am always quiet at the beginning of the surgery, noticing everything that is happening around, because that is the most important part. Check the padding of the knees and the ankles. Secure the Foley's catheter, especially in the elderly. Keep the abdomen, chest and eyes totally free of pressure. Pad all the bony prominences, especially the iliac crests. Secure the patient safely. You may be tilting the table during surgery. Check the bony landmarks and confirm with markers as to where they are intraoperatively. Check an AP view, especially if you're planning an instrumentation. Mark the level. When you're doing a micro decompression, if I'm going left side L4-5, my needle goes in on the right side at the L4-5. So it goes into the soft tissue where I'm not going to do my surgery. So I'm always on the opposite side, contralateral side. You may use infiltration or not. I used to use saline adrenaline earlier. I don't use it anymore. Choice is yours. Adequately draped, disposable or otherwise, choice is yours. Then you take the leap. After you take the leap, be very, very aware that you have to be vulnerable. Never be overconfident. When Sachin Tendulkar walked out to bat, he was always scared and vulnerable. That's how you have to be when you begin your surgery. Conventional disc surgery could be just a fenestration, Could be a laminotomy, could be an interlaminar discectomy, or a complete laminectomy. Just to show you the very basic steps of a microlumbar decompression. Expose the hemilamina. You are usually standing on the left side of the patient and you work from above downwards. I expose the hemilamina using a 1-inch dry roller pack. I use the versatile Indian version of the McCullough's retractor, which is a small pin and a small retractor on the other side. The pin goes in the interspinous region while the retractor retracts the soft tissues laterally off the lamina towards the side. I check on the C-arm the moment I identify the interlaminar window. That is most critical. Please remember the point where you are checking the level. The disc space has to be above it. The disc space is never below it. Always remember that your interlaminar window is always slightly below the disc and you have to work a little bit upwards. If God forbid you are at recheck, you may be at the wrong level. Next, identify the overhang of the lamina and disconnect the undersurface of the ligamentum flavum. Various ways of doing it. I do it with a periosteal elevator. People do it with a scoop. Having done that, if you choose to do a laminotomy, this is how it is done. After you have disconnected the lamina from the underhang of the ligamentum flavum, we can then create a larger window, keeping the ligamentum flavum there as a safety on the dura. That's the left and the right. It's a surgeon's view that I'm sharing with you. That's the type of laminotomy I would do. This is to show you what I've done on the left side. This is a bone model of the same process. And this is the amount of bone that I've removed at the L4-5 level to get to the superior edge of the ligamentum flavum. Just above the ligamentum flavum, you would see some fat where the edge of the flavum ends. That's the point that you go in and lift off the flavum. You could do it with a bent ball tipped, or you could do it with a special instrument which is devised, which is actually a 1 number which we've bent to 90 degrees, which helps us lift up the ligamentum flavum. This is the instrument I use. I go in and flip it by 180 degrees and lift off the ligamentum flavum. The central part of the ligamentum flavum always has a weakness or a rent. This can help you reflect it off. This is what I do, and I could then pick it up, hold it with a fine tooth forceps and cut on it, keeping my instrument below between the dura and the ligamentum. Having done that, we expose and lift off the ligamentum flavum. Mind you, this is just to get the plane between the theca and the ligament. The main work is on the foramen. The nerve root is on the lateral side, and that's where we have to go next. Identify the nerve root, see where it is. I always check where the nerve root is. I use the nerve root retractor, which is a double bent or a double curved nerve root retractor, to just identify the shoulder of the root and see where the disc is. Rarely, if it's a non-contained disc in the foramen, you may have to do a small rent there called the annulotomy. But before I do an annulotomy or look for my disc, I work on the nerve root. For me, the surgery is a nerve root decompression surgery. Discectomy is an incidental part to decompress the nerve root. So I identify the entire nerve root, either on my side, which is left, or on the opposite side, which is right. I do both from the left side. Having identified that, I would then have a look at the annulus and may do an annulotomy in the foramen. Otherwise, most of my discs are already protruding out, if not extruding out. Having said that, we may, as I said, do a small contained annulotomy and then pick on the best small disc punches. I use fine 2 millimeter serrated disc punches, which are straight and upward going, to identify, loosen the disc fragments, use my ball tip to further loosen it, and then see where the disc fragment is coming out. Gently hold it with my disc punch and use my 4 number, which is the Penfield, and my ball tip right angle to loosen that disc fragment and gently tease it out. That's how that 5 centimeter disc came out in the first patient, which Dr. Shreel showed us as well. Always remember, there has to be a route map. The disc has to be of the size that you predicted, and it has to be in the place where you predicted it. 5 centimeters behind L3 body, that's where we found it. Similarly, this may be 2.2 centimeters or 2 centimeters below L4-5 disc. That's where you have to find it. These are the 2 instruments, the 4 number Penfield and the right angled ball tip, which I need and use to deliver my fragments. Mind you, I only do a loose fragment removal or a bumpectomy in those foraminal discs. I don't do a complete nucleotomy. I don't scrape the end plates and get it bleeding. That's only a part of my fusion surgery. 25, 30 years back, that was state of the art. It's no more. If you do that today, you're adding to increases post-operative aseptic necrosis and instability and pain, which is discogenic. So avoid that. Be less aggressive. Just remove the offending fragment and decompress the nerve root completely. Please remember, use disc punches which have less length so that you only go up to 1 centimeter as far as the threaded portion is concerned. If you use those which are 2.5, you may accidentally go to anterior and it can be life-threatening, dangerous with a vascular injury. So be very, very careful, especially in the lateral and in the front where you go in with your disc punches. Use a curved ronger on the other side to get the fragment out if you have to. Do you have bleeding? Yes, you will have bleeding in the epidural spaces, and the epidural veins tend to bleed. How do we achieve hemostasis? I use the bipolar very, very comfortably, and I use it all over. Before exposure, after exposure, throughout. I need a clean field to work. Despite the loop or the microscope, whatever we may need or use, we keep that field free of bleeding throughout. Use the suction and the bipolar very well. You can then use gel foam or pledgets to get hemostasis. That's a subcuticular closure, and that's what your incision would look like and the scar after the surgery. Recap, this is what we do. We go in, put in our McCullough's retractor, do a laminotomy, identify the herniated nucleus pulposus, get that disc punch in, retracting the nerve root away, get that fragment out, and call it a day. Einstein said, insanity is doing the same thing over and over again and expecting different results. Well, in spine surgery, sometimes the contrary or the corollary is also true. We have to keep doing the same thing again and again in the same way every time. Please remember, the foolishness and the hunger will not stop. It is an unforgiving surgery, but at times it's most gratifying. Triumphs and turmoils are a part of the game. Self-doubt will creep in for a spine surgeon on a regular basis. How then does one keep one's head above the water? Please remember, don't let the noise of others' opinions drown your own inner voice. Most important, have the courage to follow your heart. Somehow your heart, mind, and hand already knows what you truly want to become. Everything else is secondary. Opinions are not facts. Stop worrying about what people think about you. Stay hungry, stay foolish. All of us do not have equal talent. All of us are not born with them, but all of us have an equal opportunity to develop our talent. The future belongs to the most competent. So get good, get better, and be the best. Please remember, we can bounce back and convert self-doubt into self-belief by doing the same thing better. We have to be better today than we were yesterday, and tomorrow we should be better than today. Thank you very, very much for a patient hearing.
Thank you so much, Ram sir, for such an elaborate surgical checklist and step-by-step demonstration of the most common yet the most difficult spine surgery, that is a microlumbar discectomy. I believe that there are so many points that have been covered in such a short span of about 10 to 15 minutes that probably we might not find in any of the books. And now we move on to the last part of our discussion, that is a review of literature by Dr. Abhay Rege.
Thank you, sir. After such an enlightening talk by Ram sir, and after having discussed all the different types of spine surgery, I would like to present basically what the literature says about it. Is my screen visible?
Yes,
Sir.
just make it full screen.
Yeah. So basically, we have established in the previous webinar as well as today that what the indications of spine surgery are. They are absolute and relative indications, which we've already talked about. And in today's webinar, we are here to talk about basically different types of spine surgery. So when we decide to go ahead with a surgery of a patient, these are the dilemmas that we face as surgeons. First is, do I go in for surgery at all? Which is, do I conserve weight or do I go in for surgery? Do I fuse this patient or not? If yes, how do I fuse? There are different modalities of fusion. Which one do I use? If I then decide whether I am fusing or not, then I have to decide whether I go in for an open surgery or take the minimally invasive route. Once I have decided what kind of surgery I am doing, I have to consider the complications of these surgeries and how I can minimize them. And of course, whether what I am doing will be safe or not. So the most common pathology of the lower lumbar spine that comes to a spine surgeon is a prolapsed intervertebral disc. Atlas et al. Studied the 5-year outcomes in a main lumbar spine study, in which they concluded that over 5 years, surgically treated patients continue to report significantly greater improvement. The narrowing of outcomes occurred primarily over the first 2 years and was related to continued improvement in non-surgically surgically treated patients as well, rather than deteriorating outcomes in the surgical patients. So these people basically talked in favor of surgical treatment. However, cauda equina syndrome is an absolute emergency. We do not consider whether we are operating or not in most cases when it comes to cauda equina syndrome. We talked about this study earlier in this webinar where we discussed whether cauda equina syndrome comes with retention or with an incontinence. And we also discussed that if it is an incontinence, then it gives the most benefit over the next 48 hours. If it is retention, it won't give as much benefit. However, it would be appropriate to operate upon such patients within the first 48 hours. This study was done by Todd et al. And they said that a cauda equina patient who is deteriorating neurologically must be taken to the theater immediately, and also gave certain guidelines based on retention and incontinence, which are showed here. So then the next question that arises is, should we fuse or should we not fuse? So a study by Herkovitz et al. Said on lumbar spine fusion in the treatment of degenerative conditions, basically said that arthrodesis for patients undergoing decompression for spinal stenosis, which is associated with degenerative or iatrogenic spondylolisthesis or progressive degenerative scoliosis, is supportive. Patients who undergo extensive decompression intraoperatively should also undergo concomitant arthrodesis. And the occurrence of 2 or more episodes of disc herniation at the same segment is also an indication for arthrodesis. In addition to that, Andrew Chan et al. Also did a study comparing 426 patients' laminectomy versus fusion in cases of grade 1 lumbar spondylolisthesis. What they concluded was that regardless of the treatment strategy, lumbar spondylolisthesis was associated with significant improvements in disability, back and leg pain, and quality of life at 12 months. They also had a superior ODI score at the end of 12 months. Gogawala et al. Also compared laminectomy plus fusion versus laminectomy alone in spondylolisthesis, and they concluded that among patients with degenerative grade 1 listhesis, addition of lumbar spinal fusion to laminectomy was associated with slightly greater but clinically more meaningful improvement in overall physical health related quality of life than in laminectomy alone. A study by Agarwal et al. Then decided which kind of fusion has to be done. Once we have decided that we are fusing, we have to now understand whether what kind of fusion we are doing for the patient. So Rati Agarwal et al. Did a study comparing posterolateral lumbar fusion and posterior lumbar interbody fusion, and they concluded that both PLF and PLIF provide good clinical and radiological outcomes in terms of pain, disability index, lumbar lordotic angle, as well as maintenance of disc height. Another study by Osterwald et al. Compared effectiveness of micro decompression alone versus decompression plus instrumented fusion in listhesis. What they concluded was that micro decompression alone was associated with shorter durations of surgery and hospital stay, supporting the suggestion that the less invasive procedure should be considered for most patients. So now we have one study which says that fusion is better, another study which says that just micro decompression would be better. There was another study by Humphreys et al. Which compared posterior and transforaminal approaches, that is PLF and TLIF. What they concluded was that there was significantly less blood loss in the TLIF approach, and the transforaminal procedure preserved the interspinous ligament of the lumbar spine and preserved the contralateral laminar surface as an additional surface for bone graft. So it is more beneficial. Now, to sum it all up, there are some studies which say that we should fuse. There are some studies which say that we should not. So to sum it up, like Samir sir also showed this study in his presentation, there was a study done by Kulkarni et al. In 2020, which gave us certain points over which we can decide, a scoring system from which we can decide whether we want to fuse or not. So then there was another study which was based on revision rates in patients which have had either a 2-level posterolateral fusion augmented with single versus 2-level transforaminal lumbar interbody fusion. This study said that patients undergoing 2-level PLF in the setting of an already existing TLIF using a TLIF at 1 versus both levels does not seem to influence the reoperation rates or outcomes. However, reoperation rates for adjacent segment disease are increased in the setting of 2-level PLIF augmented by a 2-level TLIF. So now what we think is the next level of fusion. We have talked about PLIF, we have talked about TLIF. What about XLIF and OLIF, which are the new kids on the block? So there was a comparison by Teng Lu et al. Between posterolateral fusion, transforaminal, XLIF and OLIF. What they concluded was that PLF has less stability than the other 3 fusion procedures owing to the greater ROM and stress peaks in the posterior instrument. The OLIF and XLIF induced fewer stress peaks in the cortical end plate and cancellous bone than the TLIF procedure, which was beneficial for the subsidence resistance and disc height and segmental angle maintenance as well. So now that we have decided about fusion and non-fusion and the types of fusion, we now have the dilemma between open surgery and minimally invasive surgery. To make a decision, first we need to understand what minimally invasive surgery really is. So it is defined as a procedure, an MIS procedure is one that by virtue of the extent and means of surgical technique results in less collateral tissue damage, resulting in measurable decrease in morbidity and more rapid functional recovery than traditional exposures without differentiation in the intended surgical goal. The surgical goal always has priority. So there is a study by Kevin Fan et al. Which compared minimally invasive versus open laminectomy for lumbar canal stenosis. They concluded that unilateral laminectomy for bilateral decompression may be associated with less blood loss and shorter stay with similar complication profiles to the open approach. So they spoke in favor of minimally invasive surgery. Another article by Mobbs et al. Compared the outcomes after decompressive laminectomy for lumbar spinal stenosis Comparison was, it was a randomized controlled trial, and the comparison was between minimally invasive unilateral laminectomy for bilateral decompression and open laminectomy. They concluded that microscopic unilateral laminectomy for bilateral decompression is as effective as open decompression in improving the function, that is the ODI score, with the additional benefits of significantly greater decrease in pain, that is the visual analog scale score. Post-operative recovery time to mobilization and opioid use also gave better results. Now, once we have talked about all the modalities of spine surgery, we come to the complications. There are a number of complications that happen in spine surgery, but the most common intraoperative complication is an incidental durotomy. So Jones et al. Studied this, and they studied the long-term results of lumbar spine surgery complicated by an unintended incidental durotomy. It was a retrospective review of 450 patients undergoing lumbar spine surgery. What they revealed is that 17 cases of incidental durotomy, which were recognized intraoperatively and repaired primarily. These cases were studied. What they found is that there was no difference of statistical significance between the two groups. Incidental durotomy, when recognized and repaired intraoperatively, does not increase the perioperative morbidity of compromise or compromise the final result. So what they said basically is that incidental durotomy, although can happen intraoperatively, it doesn't really impact the patient's recovery as much as is thought. Now, there was also a study by Ramprasad et al., which studied the overall intraoperative adverse events and related postoperative complications in spine surgery. What they concluded was that the adverse events can occur frequently, as high as 14% during spine surgery. However, the majority, that is 76.5% of these, are not associated with complications. Now, when we read this sentence, it is a very confusing thing. How can we accept a rate as high as 14%? So when we look at their background data, what it shows us is that in this study, adverse events were defined as any unexpected or undesirable event occurring as a result of spinal surgery, not its implications. Whereas a complication was defined as a disease or disorder, which as a consequence of a surgical procedure will negatively affect the outcome of the patient. So basically what Ramprasad et al. Wanted to say was that events can occur during surgery, but they do not actually impact the overall consequence, the overall result of the surgery. In the end, I would just like to say that spine surgery is safe. It is not as scary as was thought probably half a decade ago, and it can be safely done, as amply talked about in this whole webinar by Sameer sir as well as Ram sir, and demonstrated very well by Shreel and Omkar in their cases. Thank you.
Thank you very much, Abhay. That was an extensive review of literature, and it has covered all the important points that would come to any surgeon's mind before he embarks on practicing safe spine surgery. First and foremost, I would like to thank each one of you for having participated and shared your experience. If there are any questions from among us, we would first take them and then look at questions coming from the chat box. So any questions from Omkar, Shreel, Abhay, Sameer, any questions? We could take them first.
So my question was, a laminectomy first or an instrumentation first? So if you are planning for a surgery with decompression and stabilization, in the lumbar spine, do we do a laminectomy first and then instrumentation, or instrumentation first and then laminectomy? And does this differ in lumbar and thoracic differently?
Okay. I'll tell you my take. From 1990 till about 2010, maybe even 2012, I always decompressed first. I used to decompress, finish my decompression, and then do my instrumentation, having covered the decompressed area with moist gauze pieces, and carefully do my implantation later. What did that teach me? and how do I now follow things? Well, that taught me that there are times where you would have unexpected conjoint nerve roots, root anomalies, certain pathologies which conventional 1.5 Tesla MRIs may not pick up, and which would get or could get impaled if you were doing an instrumentation first approach. However, today, where a lot of these root anomalies are picked up by us, a lot of hypoplastic pedicles are picked up by us, a lot of abnormal anatomies, congenital or developmental, are picked up by us preoperatively in the imaging, we can plan a safe instrumentation in most times, and hence in standard looking spines, putting your screws in first would be a routine followed by most people. Yet, if you are doing high-grade spondylolisthesis, if you are doing situations where the pedicles are hypoplastic, where you are suspecting more than root anomalies, or you're doing a congenital spinal anomaly with thecal as well as bony abnormalities, in those patients, identify the anatomy, identify the safe corridors, check out where the roots are, and then go in. Like if I'm doing a high-grade spondylolisthesis, I do a complete root release on either side. I see how small my L5 pedicles are, how deeply they are placed, and then I would go in. Because if I was to be doing a high-grade spondylolisthesis without identifying where my L5 point of entry is, it would be purely radiological, and my chances of going wrong would be higher, rather than visualizing my roots and putting it in. So from a time where I used conventional X-rays, lower CT and MRs, to a time where I've now gone on to a 3 Tesla MRI, where I can ask for my cuts the way I want, I am now using my decomp first less often than what was a rule earlier. So this is how I practice today. Standard spines instrumentations, I don't necessarily identify the roots, but wherever I'm suspecting the roots or the pedicles to be abnormal, I would first identify the neurological elements before putting my implant in.
Thank you, sir.
So I would like to ask one question. So you have been a pioneer of minimally invasive spine surgery as well as robotics and navigation. So I would like to ask you how it has implemented your practice over the years, these advances in spine surgery.
Okay, minimally invasive spine surgery is the way to go for the present and the future. It reduces collateral soft tissue damage to a large extent, but it does not mean just putting the implant in. Please understand that you have to train yourself adequately and very well to do as good, and mind you, if not better, decompression, which is the integral and most important part of most surgeries. So please understand, train yourself, whether it is with the operating microscope, whatever it is, you train yourself and do, whether it's through the tube, whether it's percute, whatever you are doing. There are various subdivisions of minimally invasive. Don't extend the indication, in the sense, train yourself. What is it that you can do transforaminally? What is it that you can do with an interlaminar? What is it that you can do uniportal? What is it that will need a tube? What is it that will need bilateral tubes? Where can you put percutaneous screws? You should train yourself for everything. That's the way to go ahead as far as minimally invasive is concerned. And believe me, it is surely far better if you can do justice. But please remember, the very elderly, where you practice minimally invasive, be very, very careful in what you do. If you're doing minimally invasive in a multi-level, multi-segmental, multifactorial lumbar canal stenosis, please understand what I'm saying. And if you cannot do justice with minimally invasive, don't shy away by offering that patient a proper decompression. Because what the elderly come to you for is claudication. What they come to you for is improvement in quality of life. If they are good enough to stay in bed for a couple of days and be in your hospital for 3 to 5 days post surgery, you don't have to sell them the fact that I will send you home the next day. So please do justice to that patient. Practice minimally invasive in the young patients, in those who have monofactorial pathologies rather than multifactorial pathologies, because you may not be able to do justice. Next, robotics today is limited to safely putting in implants. It is now extended to safely putting in interbody spacers. So it is looking at the mechanical part of the surgery. It's not yet enhancing the biological part of the surgery. It's not yet allowing us to safely handle neural elements where neuromonitoring is an added adjuvant. As and when neuromonitoring marries navigation or robotics, that is going to be the next paradigm shift, where one device that you're holding is going to cut the bone, is going to do it and identify your point of entry, and is also going to stay away from the neural elements. That's the time when a lot of things will change. A lot of inoperable pathologies will become operable. A lot of difficult pathologies will be addressed better. So this is happening and is the way to go. So don't restrict yourself from training, but don't overindulge or over-promise the patient. So promise and deliver more than you've promised rather than promise and not be able to deliver. And begin your journey with lesser cases which are less challenging before going into the higher, more challenging cases. But yes, practice minimally invasive. It is the way to go. Absolutely.
Thank you, sir.
Any other questions from anybody? If there aren't any other questions, on behalf of the entire team, Dr. Samir Ruparel, Dr. Shreel Koirala, Dr. Avyay Rege, and Dr. Omkar Shinde, I thank Intergrace and I thank our hosts for arranging this gathering where we have discussed our hearts out, and I hope and pray that the discussion among the six of us has added value to the learning and the experience of the delegates who have attended this. When I said six of us, it is the 5 people you saw and that one patient who has allowed us to discuss his or her pathology with you and share the experience. So on behalf of our entire team, we thank Mr. Fernandes, Meenal ji, Shekhar, and everybody else who has made this possible. Thank you so much, and over to you, Anil.
Thank you so much, sir. I think what an engaging and absorbing session it has been right from the word go. And I think the participation and the attendance that we had today bears eloquent testimony to the learnings and the quality of discussions we've gone through. Sir, and the entire team of faculty members, you would be very proud to know that we had more than 700 doctors today who were hooked on and absorbed to the discussions. I think very interesting cases, traversing the gamut of challenges and issues that you face on the surgical side of the spectrum of spine disorders. And I'm sure the pointers what all our experts have given will be clinically very relevant and useful to all our viewers who logged in this evening. To all our viewers, we owe it to you. It is your support, it is your encouragement and enthusiasm that drives us to try and help you better in terms of giving quality from the experts. Thank you, Dr. Ram, sir. And thank you, each and every of our faculty member, for this brilliant discussion that we had this evening. It's been truly enjoyable and absorbing. Thank you very much. Have a wonderful day and a wonderful weekend. And please take care and stay safe.